How's it going, guys? So we have a very difficult hematology/surgery question for 2CK. I agree that this question has absolutely nothing to do with surgery, but it's not my opinion. A nearly identical one shows up on one of the 2CK NBME subject-specific clinical mastery series forms for surgery. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. Find me on Instagram at Mehlman_medical, MEHLMAN_medical. Link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's start the clip. So 20-year-old man, he has a painful erythematous left leg, 3 episodes of superficial thrombophlebitis the past 4 years. Duplex venous ultrasonography confirms a DVT. Question just wants to know the most likely diagnosis. So we have a very vague vignette here. Okay, a young adult who has recurrent thromboses, not much to go by. So let's just walk through the answer choices here. Choice E, von Willebrand disease, wrong fucking answer, albeit exceedingly high yield for USMLE. This is autosomal dominant. 14 out of 15 questions will present as a mix of one platelet problem and a clotting factor problem. So platelet problems, generally mild cutaneous findings, petechiae, easy bruising, ecchymoses, as well as epistaxis, which is nosebleeds. Clotting factor problems being excessive bleeding after tooth extraction or circumcision, that's high yield for pediatrics, as well as menorrhagia, heavy periods in women. Hemarthroses as well, although those tend to be more hemophilia rather than von Willebrand disease. Von Willebrand factor bridges glycoprotein 1b on platelets to underlying collagen/vascular endothelium, so important for platelet adhesion, not aggregation, okay? And it serves a secondary/ancillary role of stabilizing factor VIII in plasma. So bleeding time, platelets, PT, PTT, clotting factors. So because the main role of von Willebrand factor is to mediate platelet adhesion, we always have an increase in bleeding time. But because it's a mere secondary role to stabilize factor VIII in plasma, PTT is only increased in about half of NBME questions, all right? Students often erroneously think that bleeding time and PTT are always increased. It's not the case. PTT only increased in about half of questions. Wrong fucking answer. Choice D, thrombasthenia, wrong answer. This refers to, it's a fancy term that refers to general platelet problem, okay? If we had to converge on one specific diagnosis, this could refer to perhaps Glanzmann thrombasthenia, okay? Fancy diagnosis that refers to congenital deficiency of glycoproteins 2b/3a on platelets for platelet aggregation, okay? When we talk about these sophisticated sounding diagnoses like Bernard-Solier, Glanzmann thrombasthenia, students get fanatical about them being high yield, but they're not. Exceedingly low yield / practically non-existent as correct answers on NBME material. Wrong fucking answer. Choice C, hemophilia, wrong answer. X-linked recessive for hemophilia A and B, deficiency of factors 8 and 9 respectively. So you're going to have an isolated increase in PTT, okay? Bleeding time and PT are normal. It's going to present as a school-aged boy who has a hemarthrosis, so bleeding into a joint, as I said before, as well as excessive bleeding after circumcision in a neonate. Very high-yield presentations. If they give a patient factor 8 or 9 respectively for A and B, and the PTT does not come down, then the answer is going to be antibodies against factors 8 and 9, okay? Wrong answer here. Choices A and B. Now we're between anticardiolipin antibodies, which can cause antiphospholipid syndrome, or just an obscure diagnosis, antithrombin 3 deficiency. Now, anticardiolipin antibodies or anti-beta 2 microglobulin antibodies can cause antiphospholipid syndrome. If we have a patient who has lupus who has either of those antibodies, we just call those antibodies lupus anticoagulant. Now, antiphospholipid syndrome is going to present as a patient who has recurrent thromboses despite an increase in PTT. It's paradoxical, okay? If PTT is up, you'd think you'd have bleeding diathesis rather than thromboses. Thing is, you need phospholipid for the in vitro PTT assay to work, okay? So that assay will not work, so PTT is elevated. But in vivo, we get thromboses because antibodies against phospholipids can cause clumping of platelets and clotting factors, okay? So this is the wrong answer in this case because they don't mention anything about PTT here. Okay, as I said, it's a very difficult question, but if they want antiphospholipid syndrome in USMLE and they give you a relatively vague vignette, they would tell you PTT is elevated. Another important detail is that antiphospholipid syndrome causes recurrent miscarriage in lupus. Okay, so I said you can see it in lupus. They give you a woman who's had recurrent spontaneous abortions. You need to know that that's antiphospholipid syndrome. Okay, that's probably the highest yield presentation on USMLE for it. So antithrombin 3 deficiency is the correct answer. This is going to present one of two ways in USMLE. Number one, just like this, where you have a young adult who has just a vague presentation of recurrent thromboses, nothing else to go by, okay? And in the absence of other thrombotic disorders, I mean, there are others, factor V Leiden or factor 5 Leiden, prothrombin mutation, okay? So there are other conditions, but they're not going to list them all together. It's going to be a vague presentation of a young adult, and you need to know this is actually hereditary, okay? That's the first way. The second way it presents is a patient who has nephrotic syndrome who's losing antithrombin 3 in the urine, okay? It's still a protein, and the patient's going to get renal vein thrombosis, all right? So you could have a diabetic with chronic renal insufficiency with severe nephrotic syndrome, renal vein thrombosis. That's another way antithrombin 3 deficiency can present. As I said, very difficult question, okay? But if anticardiolipin antibodies were the answer in a patient like this, then they would tell you PTT has increased. Otherwise, they would tell you a pregnant woman who's had recurrent miscarriages, okay? You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel. And I appreciate your time. That's it.